Hello, everyone, and wherever you are in the world right now, thank you for joining us. I'm Lawrence Webb, Vice President of IOSH, and I'm your host for today's session. IOSH is the world's chartered body for health and safety professionals, and today we embark on the second part of our three-part series called Building Health and Safety Practice for a New World, where we're looking at how occupational safety and health and all of its partners can embrace a new life beyond the COVID-19 pandemic. Now, over the course of this year, more than 3 billion doses of COVID vaccine have been administered in over 190 countries worldwide. And while the future is now looking far more hopeful, we move forward with a tenth of those who caught the virus continuing to live with the very real and seriously debilitating condition of long COVID. Now, you heard me correctly. Around 1 in 10 hit by the virus will develop long COVID, regardless of how mild or severe their symptoms. We've seen the wide-ranging impact that COVID can make on our respiratory, cardiovascular, musculoskeletal and nervous systems. And for many of those living with long COVID, even the basics of dressing and bathing, for example, present an unrelenting daily challenge. Now, for these people, getting back to work will pose a challenge of a wholly different order. So today, we're going to address the full might of the long COVID legacy and begin to explore how we can build the right conditions for a successful return to work, and so aid people's recovery from this persistent and cruel condition. Now, I'm delighted to introduce the first of our panel for today. First up, and also delivering a short opening presentation, is Dr. Karen Michel, Research Programme Lead with IOSH. Karen is an occupational health practitioner of over 25 years of international experience, spanning occupational health, safety, research, and education. Her professional experience is underpinned by a strong academic and research background, which extended into IOSH consultancy in the pharmaceutical, construction, logistics, healthcare and manufacturing sectors. A recipient of multiple awards and scholarships recognising her performance excellence, Karen was made a Fellow of the Academy of Nursing in South Africa, and this marked her contribution to research and practice in occupational health nursing. It's great to have her here with us today, so welcome, Karen. Next, we have Professor Anne Harris, immediate past president of the Society of Occupational Medicine and professor of occupational health at London South Bank University. Anne has extensive teaching and course management experience, both at London South Bank University and previously at the Royal College of Nursing. She's driven the development of occupational health education and practice locally, nationally and internationally. And we're really grateful to her for taking the time to join us today. So welcome, Anne. And finally, all the way from Johannesburg in South Africa, I'd like to welcome Dr. Murray Dryden of the National Institute for Communicable Diseases Division of National Health Laboratory Services. Murray's a medical officer who's been with the NICD in South Africa since February 2020, where he was a part of the Outbreak Response Unit and assisted with clinician support throughout the COVID-19 pandemic. Murray joined the DACCOV National Hospital Surveillance Team in October of 2020 and has led the NICD Long COVID project ever since. Now, currently, their study has enrolled over 2,500 participants with a planned 12-month follow-up period, and they're looking to publish their findings soon. Now, unfortunately, Murray's webcam is currently broken, so he can't be there on screen. I promise you he is actually there, but welcome, Murray, and a big thank you for joining us today as well. So that's our panel. Now, without further ado, let me start by handing over to Karen, who'll set the scene with a short presentation that looks at exactly what long COVID is, how it can be tackled in the context of work. So over to you, Karen.
Thank you very much, Lawrence, for those words of introduction. I'm going to try very concisely to give you a background to long COVID and rather use the time for questions later on. I want to start off by saying this is a new syndrome. It's a condition that is between 16 and 18 months old. It's still being investigated, and we really are at the infancy of the knowledge that we have about the condition. Long COVID itself is not a medical term. It's a term that was coined by a group of long COVID sufferers who decided that this syndrome needed a name. And it goes by a number of pseudonyms as well: post-acute sequelae of COVID-19, long haul COVID. But where we can say we're at is that the NICE guidelines in the UK have now provided us with two definitions that we can use to describe people who are suffering with long COVID. The first being ongoing symptomatic COVID-19. Now that describes patients who between 4 to 12 weeks after the onset of their original acute infection are still symptomatic. And it's estimated about 1 in 5 people will develop this. And then you have those patients who are suffering what is then called post-COVID-19 syndrome. And it describes all of those people who more than 12 weeks after the onset of their original infection are still suffering with symptoms. And as Lawrence said, this is estimated to affect about 1 in 10 people. But let's put that into context. I've taken these figures from the Global Worldometer for COVID-19 on the 17th of August. And then it was reported that as almost 209 million people had been tested positive for corona virus infection, or what we call COVID-19. Of those, we've had just under 4.5 million deaths. But the positive side is that over 187 million people have recovered from their acute infection. The problem is that we have estimated that about 1 in 10 will go on to develop long COVID. And on these conservative estimations, we are looking at more than 1.8 million people who will suffer long COVID. So then you ask yourself the question, well, who gets long COVID? Well, it's not an easy question to answer, because in reality, one would think, well, those people who were hospitalized, who had severe cases of the COVID-19 infection would be the ones to go on to develop long COVID. However, that's not the case. Not only are those patients reporting long COVID, but people who in the beginning had less severe symptoms, who maybe weren't diagnosed because we didn't have the testing capacity then that we do now, and who were managed symptomatically and encouraged to stay at home until their symptoms have passed, have gone on to report symptoms of long COVID. But what the research has been able to show us is that there are groups of people who are possibly more likely to go on and develop long COVID as a consequence of the original infection. And this includes people who have pre-existing health conditions, diabetics, asthmatics, hypertensives, older people, overweight and obese individuals. Women are more affected than men. And then, quite interestingly, patients who had 5 or more symptoms in the first week of their COVID-19 infection are deemed to go on and develop long COVID. So we talk about these symptoms. What are they? Well, this is a very busy slide. It is intentionally a busy slide because the research again shows us there are over 50 reported symptoms of long COVID. Now, COVID-19 infection affects a number of systems within the body: respiratory, your central nervous system, cardiovascular, musculoskeletal. And the symptoms that people show are related to the systems in the body that are actually affected. So over and above these 50 plus symptoms that have been reported, there are actually a group of common symptoms that are seen more frequently than others. And they include things like fatigue, shortness of breath, muscle pains, chest pain, brain fog, headache, and depression. So looking at these symptoms, we then are led to ask the question, well, what are the consequences going to be of long COVID? And I think this is where it becomes extremely important for us to understand that we are looking at health consequences of a syndrome that we are still learning about. People who 16 months after their acute infection have persistent and fluctuating symptoms. Patients report that their symptoms can be so debilitating that they can't even conduct the activities of daily living. And people who are going to need, for an extended period of time, ongoing rehabilitation so they can get back to as near normal for them as possible. But then you're going to have the challenges in the working environment as well. The ability to return these workers to work safely, linking the abilities that they now currently have with the work demands, puts a whole new scope on this fitness to work. And then you're going to have the challenges of management's attitude to accommodating the return to work process. How are managers going to feel when 12 months down the line, workers are still struggling symptomatically and unable to return to normal work? And then on a larger scale, your social and your economic consequences. There's going to be financial impacts on the individuals and society. We're going to be challenged by the societal attitudes to sufferers. Is it going to be a case that once this pandemic starts to wane and we are getting back to a sense of normality, that the compassion for these individuals is going to wane at the same time? And then what are going to be the challenges towards the social security systems, especially in economies where your social security is still immature? So there are going to be challenges for us as professionals moving forward. But I just want to again just share some numbers with you and looking at the impact on ability to work for people with long COVID. And just in numbers, 84% of sufferers say it limits their activity. 81% brain fog hinders their ability to concentrate. 85% say they have persistent fatigue. And then almost 50% talk about difficulty managing stress and doing basic tasks. And the reality is all of these symptoms are going to limit the intensity and the duration of work that can be performed by these individuals. In fact, so much so that long COVID sufferers have reported in 75% of the cases that it has affected their ability to work. 60% have taken time off because of long COVID, and 45% of them have said they have returned to work with a reduced capacity. So I think the understanding is clear. It's that for many workers, it's not going to be a case of it's going to work after long COVID, but returning to work with long COVID. So then you might say, well, why go back to work at all? Well, the reality is the worklessness kills. We need to facilitate a safe return to work for these workers. Workers don't have to be 100% fit to do work, and we need to work within this framework. And we need to understand that the ability to work is an important part of the recovery process for these individuals. So we need to give considerations to the employment rights and benefits that are available, access to individual benefits, healthcare, sick leave, financial support, possibly disability packages. And then we need to start looking at the role that the IOSH professionals themselves are going to play. And when I talk about IOSH professionals here, I'm talking about safety professionals and the health professionals. We need to remember that we are going to see the people who have function, but with limitations. And it's our responsibility to facilitate that safe and healthy return to work for these individuals. And it's going to be based on their abilities rather than their disabilities. And I want to just give you two examples here. Your office worker. Your office worker who has brain fog, who sits in front of the computer all day and is required to concentrate and make decisions. They are going to struggle. They may have the physical capability, but they need that cognitive ability, which is now being hindered. And then quite on the opposite side, your construction worker who may have no cognitive dysfunction, but because of the musculoskeletal, cardiovascular, or respiratory impact, he is not going to be able to fulfill his work demands at work. So how are we going to then, as professionals, manage these individuals? I'm not going to go into too much detail because I think that's what we'll do in the panel, but I think it's important to understand we're going to need a planned, supportive, and coordinated return to work. No more so than now is that multidisciplinary approach to the management of the workers' well-being so important. It's going to be necessary to do case-by-case management. No heterogeneous groups here that you can just put a label on and say, this is how we're going to manage them. There's going to be a need to conduct an individualized risk-based approach to ensuring fitness to work. It's possibly going to have to be a phased approach, which is going to change from day to day as symptoms fluctuate and change. It's going to demand flexibility, the ability to accommodate these changing symptoms and the impact on the individual, and no more so than trying to create that hybrid working environment where the worker feels comfortable and able to work. And I think what is also going to be important, this isn't a once-off assessment. There's going to be a need for frequent reassessment and accommodating the needs of the individual. So without too much ado, we are looking at a multidisciplinary approach that's going to be very demanding, that's going to need collaboration between safety, health professionals, management, etc. And in the middle of this is going to be that worker who is suffering with long COVID. For how long, we don't know, but we're going to need to manage those scenarios. I've provided here a number of resources that you can use to go and look up some of the strategies for managing workers' well-being in the workplace. And as well as that, I've provided you here with a list of references. But I think a lot of what needs to be done is going to come out of the panel questions now. So thank you very much.
That's great. Thank you, Karen, for the overview and for helping to put in place the context for the rest of this session. So I'd like to ask now for Anne and Murray to come and sort of join us. Murray, I do know you're still there. So just thinking about some of the questions that we had to one side, and looking at the Q&A that's coming through. I think some of these are going to overlap. So perhaps if we start with yourself, Anne. I mean, clearly long COVID is a term that's being widely used, and Karen's just talked a little bit about that, but could you paint a bit more of a picture in terms of what it means for those personally who are actually affected by it and what impact it's having on their lives?
Yeah. Initially, when COVID was first recognised, it was thought of as being a respiratory disease because you got a cough. However, what we know now is it's not as straightforward as that. And in fact, it can affect every single system of the body. And it's more a condition of the circulatory system as much as the respiratory system. So you get it through respiratory issues, but it impacts on lots and lots of different systems, which means that it impacts on quality of life and quality of health. There was a question earlier, I think it was from Stephen, saying something like, do people get depression as a result of the lockdown, or is that long COVID associated? I suspect that it could be a bit of both. However, when you think about how it impacts on what you can do, and I know several people who have developed long COVID, and the change to their quality of life is significant. And a few of those people have in effect retired on the grounds of ill health as a result of them not being able to carry out their activities of daily living to the extent that they used to be able to do. And that's impacted on their ability to carry out an effective function in the workplace.
Okay, no, interesting. I mean, Murray, could I bring you in for a bit of a view as well? Is there anything you'd add to what Anna's just said?
Thanks, Lawrence. So I do think it's a very difficult question to answer with any level of certainty. Obviously, the best person to ask about what long COVID means to them is someone who's affected by it. And there are many hundreds of papers written by world-renowned doctors and scientists around the world trying to paint this picture very nicely for the general public and for other scientists alike. But unless you're experiencing it for yourself, you won't really have a good idea of what this answer is or what this picture looks like. From what our data is saying, and from what I've been reading, it looks like the simplest way to put it is that it's this unrelenting exhaustion that just doesn't go away, and it's from a multitude of factors. So fatigue is obviously the most common one that does have a significant impact on patients, and this is both physical and mental fatigue, somewhat more mental in some instances. And this stretches well beyond the work and occupational health standpoint. So patients who are fatigued are still struggling to enjoy normal life. So even with lockdowns becoming more relaxed, socializing with friends and family or playing sports and doing exercise is also becoming very tiresome for them. Then in addition to that, some patients are reporting beyond the general fatigue, this general muscle weakness, which is also concerning, particularly for manual laborers. So the more acute symptoms are not really present. They're less common relative to the other two, but interesting, the patients report higher levels of shortness of breath of 1 month after hospital discharge, which is quite interesting. Beyond that, the typical physical manifestations with patients, they also have problems with the concentration, memory, and other levels of cognition. And the depression, anxiety has something that we've also picked up with patients. The question with regards to, is this purely because of long COVID? Ultimately, we're not really sure at the moment. We don't have significant control groups to compare that to, but it may be something related to the lockdown, or it may be related to long COVID. But it is a very difficult question to answer.
Okay, well that's great. Thanks for the insight, though, Murray. I think all these little pieces help piece together the bigger picture. I mean, it seems like quite a good time to actually move on to the next question. If I can bring you back in, Karen. Actually, is long COVID actually considered to be an occupational disease, and if not, why should employers be so concerned about it?
Not a straightforward answer again, I'm afraid, but the reality is yes and no. So let's focus first on the yes. So an occupational disease is one where there's a direct causation between work and the disease. So let's use healthcare workers, who in this example are probably the best people to focus on. Healthcare workers don't have a choice. To do their job, they're working face to face with patients. Those patients are COVID positive. And in many cases, the healthcare workers are working with them before that diagnosis is even made. So in those scenarios, the healthcare workers who then go on to develop COVID-19 and then ultimately long COVID would be considered suffering from an occupational disease. One of the tragedies, in my opinion, is the fact that they first have to be able to prove that they had that exposure, which I think in a pandemic, I question why we have to go down that trail, but that's my personal opinion. Where the answer is no, it's based on, for example, that office worker who you're not required to work face-to-face with somebody who has the disease, but because of the fact that you are at work together, you may very well get it. But because it's not a direct consequence of your job, the answer then is no. So the second part of your question is why should employers then, take heed of the fact that workers then have long COVID? And the reality is that employers invest in their workers. They have a significant investment, intellectual, financial, on many levels, and it just is good business sense from a business point of view, but it is good an ethical and moral standpoint to actually take care of your workers. Your workers shouldn't just be viewed as working machines, but they are complex individuals and groups of people who have brought businesses to the point where they are. So yes, I believe that businesses should be invested, but I'm then going to hit the reality button and say the challenge with long COVID is going to be how long. So, yep, it's a difficult one to answer, but from the point of view of an occupational disease, again, yes and no.
Okay, Anne, anything to add?
Yeah, I think that's a very good point, Karen. In fact, Layla Moran, who's an MP and chair of the all-party group on coronavirus, is actually campaigning to make it an occupational disease. And I'm glad you picked out healthcare, and you can also say social care staff, because they are particularly high risk. They don't necessarily know that the patients that they're seeing, they may come in with a broken leg, but they may be hatching COVID. So I can see the issue for healthcare staff. However, it's a bit more difficult in relation to people who work in other settings. So, for example, transport drivers, because they may have developed COVID as a result of their work processes, working with passengers, or they could have got it in the staff canteen, or they could have got it in their shop. So whether that's Sainsbury's or Waitrose or Lidl or wherever it happens to be, you don't know. So it's a really difficult one. I'm glad that she's interested, and I'm glad that she's taking that forward. Denmark, Italy, and Germany have already made it prescribed diseases. So it's a difficult one, and I think very difficult to prove that causation unless you've been working in a healthcare setting. But even so, even if you're working in somewhere like intensive care with very sick COVID patients, the control measures should be such that you're protected. So it's a bit of a hot potato.
Yeah, no, certainly. I can see that this is an extension really of the fact we are really learning all the time, and there will be lots of different cases of different variations, some of which are obviously going to be tested, I suspect, in the future. But let's think about the really important aspect of a worker returning to work with long COVID. I mean, maybe I can come to you, Murray. I mean, have you got any examples to show how much of a challenge this actually is for people returning to work with long COVID?
So I think first and foremost, when you're managing patients after COVID-19 disease, irrespective of their long COVID status, the point being put across in every single paper that I've read, every single website that's CDC, NICE, anything like that, is a graded return to work. So this includes return to work for office workers, skilled, unskilled laborers, and even including professional athletes or sports people. So in some instances, working from home is a really good way to ease these employees back into the work environment. And it not only limits the risk of infections within cramped office spaces, but it also allows for a more flexible work environment where employees can complete their assigned tasks in a comfortable environment with less time wasted commuting and other distractions. But you also need to take in consideration the other distractions that you may have at home, such as small children or television or anything else that may be going on. So moving forward, I think a combination of work days from home or working in the office will allow for a very flexible, gradual return to normal working structure, which is a good compromise that will be beneficial to some businesses. Just for example, there are some companies in South Africa that have given greater freedom to their employees, where they've been given the option to either work full-time from the office, they do half and half, or they work completely at home. And this has given these businesses the opportunity to either downsize their workspaces and sublet their spaces, as well as ensuring the employees the ability to complete the work in the most suitable environment for them. Obviously, they do have other measures in place to ensure that their deadlines are met, but it'll be very interesting to see in the future what the outcomes are. On the other end of the spectrum, what do companies do when employees are performing manual labor or in the hospitality industry, for example? In these types of sectors, it is extremely difficult to put these flexible work arrangements in place. And particularly within the hospitality industry, they simply cannot afford to have people working from home. It just doesn't work. So for example, again, the South African hospitality industry came to a grinding halt last year with the closure of borders and restaurants and hotels, as well as the prohibition of alcohol. And some of these businesses have managed to survive, barely, but it's come at a great cost. And those who haven't, they've lost their businesses, people have lost jobs, and we've seen a significant drop in the employment rate in South Africa. And beyond the job security, as much as possible, we need to allow these patients and sufferers with long COVID to return to work with this appropriate support and rehabilitation. And that needs to be the responsibility of everyone. It's not only the responsibility of the employee or the employer. The government also needs to come to a table. And as Karen has said, it's a multidisciplinary approach that needs to be taken with all forms of illness and disease. And it needs to be very individualized to individuals with different strategies for management.
Yeah, I think that's a very, very full answer. Thank you, Murray. I suspect that this will be a particular question area that people who've taken the time to dial in today will be interested in. So I'd like to see if either Karen or Anne, if you've got anything to add to that. I mean, there's a very detailed answer, as I said. Thanks, Murray. Karen, anything you'd add?
You know, for me, the management of somebody with long COVID should be no different to any other worker that you're managing in your working environment. And that is that it's risk-based and it's based on what their capabilities are. You know, so for the IOSH professional, you just go back to all your basic principles of how to ensure fitness to work in essence. The difference being that this is going to be worker-centric, that you're going to have to focus on what the capabilities of the individual are, what are the demands of the work, how can you realistically make accommodation for the needs of that particular worker. And it might even be things like they can come into work later because they just, they struggle to get through activities in the morning. Give them the flexibility that, by the time that they're tired in the afternoon, let them go home if they have to be working in the workplace. So it's going to be very much a case of case-to-case management and be led by the worker. So often in my experience, we don't listen to the worker, that these are the rules and you work by the rules. And I think this is going to be one of those scenarios where you have to stand back and say that just because worker A is capable doesn't necessarily mean that this individual is going to be. So, and again, for me, and I have to reiterate, it's going to be that collaboration between the health professionals and the safety professionals. What are the risks at work? What is needed? So often those job specifications aren't in place. Well, now you may very well be backtracking and getting them in place so that the health professionals can match up and give you a suitable recommendation. So I see this as a significant opportunity for collaboration between the disciplines. But I think, remember, go back to basics and keep this worker-centric as much as you can.
Great, thank you. Anne?
Yeah, I would totally confirm everything you've just said. I think the need for multi-professional working is just essential. And I think this has highlighted the importance of that, because the safety professionals will be very much looking at the work from a risk-based approach, whereas the health person is more aware of the impact of the condition on the health. So working together and collaborating is the best way forward. And I really want to endorse that. It's essential. And we've not worked well collaboratively in the past. So in some areas they do work well, but generally it tends to be safety, health. Now's the opportunity to meld them together and take this forward.
Absolutely.
And I think the other point you made about taking the lead, about helping that person return to work from the worker, from the patient, because they are the expert in their own health condition. They know when they get tired, they know what they can and can't do, they know what would help to facilitate their return to work. It's then a management responsibility to see how they can best fit modifications to help them do that return. And it might be, as you were saying, that they start work later. It avoids them going on public transport at busy rush hour times, which is tiring for somebody that's well. And it might be that they work partly at home, partly in the workplace, but be led by the patient. The other thing there was a question about is long COVID a disability? Well, that's interesting, because rather than having a label which says, if you have got this condition, you are definitely disabled, I would rather look at it a different way and think, how does that condition impact on the person's health status? And the Equality Act says that if you've got a long-term condition that is lasting for, or is likely to last for 12 months or more, then it should be thought of as a possible covering by the Equality Act. But as we all know, it's only a legal decision, it's not a medical decision. But if it helps somebody get back to work by making those recommendations for effective modifications, leaving it then to management to see what they can and cannot fund, then that's going to support the worker back into the workplace.
Yeah, interesting. I mean, a couple of questions that we were going to look at in terms of who's best placed to help and what support do they need. I think we're already talking around those things. But what I'd be interested to hear, maybe from yourself, Karen, is whether you think there's a role for co-workers in actually helping colleagues with regards to their return to work.
that they do have a role to play, and I think one of the big roles is being part of that supportive environment that the worker needs to get back to work. People with long COVID, the concerns that they express are fear, anxiety. When is this going to end? We can't tell them. Is this my new normal? We can't tell them. So they're living with that constantly. And then having, Jack next door commenting about the fact that I'm carrying somebody else's workload is not going to be conducive to creating that supportive environment. So whereas I'm not saying that co-workers must take on the absolute burden, what they need to understand is this is new. When we are still very unsure, but we need to provide the support, be understanding of somebody, for example, who comes into work a couple of hours late. There needs to be an element of trust that is created in the working environment, and trusting that these people are really trying to do the best that they can, and we need to help them, achieve and reach their near normal and as soon as possible. So for me, largely it's that supportive environment. So we've seen it before, is that, when something's a hot potato, everybody's excited about it and everybody is supportive in engaging. But now that we're starting to kind of go back to a near normal, we're starting to do things that we weren't doing in the past, people must understand that there are going to be those long COVID sufferers in the community who need continued support. It's not over for them by a long stretch of the imagination. So we need to be behind them.
I mean, certainly from a personal point of view, I would hope that if there is one positive thing that's come from this terrible scenario, it's the fact that people are now more open to thinking differently and being more accepting of the fact that there are more than one, different ways to do things. And certainly in my experience, employers have really seen that element of trust come out between themselves and their employees, and the fact that dynamic working, flexible working, and these other things have now become the norm. And hopefully people who are suffering the effects of long COVID will get that same approach as a result. So yeah, interesting. Thank you. So Murray, coming back to yourself, I mean, it will be wrong of us to neglect the fact that we're talking about a global world of work here. So from your perspective, is the challenge of long COVID perhaps greater in certain parts of the world? And if so, where do you think that is? And what particular, if you like, special support might be needed in these areas?
Yeah, so it is a very difficult topic. Again, there's so much uncertainty with regards to long COVID. I think we sat on a Delphi for the WHO over a month ago, and we still haven't come to a conclusion on what we're actually going to include as a definition, what the final name for long COVID and all the associated syndromes will actually be. I think the low to middle income countries, developing countries such as South Africa, will be involved. I think all of the countries, it's not only these smaller countries, smaller economies that'll be affected, but it will be a responsibility of all of these parties involved to come to the forefront and dealing with the situation. So it'll move from individual healthcare workers on the ground within the clinics and hospitals, as well as department heads and the individual departments of health that'll be quite significantly affected, to try and mitigate the amounts of impact that long COVID can have on the workplace. Just for example, South Africa's unemployment rate remains around 28% at the last census. And I'm sure, although I don't have evidence for it, that since the beginning of the pandemic, this number has definitely risen. And at this point in time, no country can actually afford to have people unemployed. Everyone should be working, not only for the economy, but also for the psychological well-being for all of these patients. And because of the global pandemic and the shutdown, there have been these lower and middle income countries that will feel biggest hit. In countries where working remotely isn't possible and these employees have no choice but to commute to workplaces, where they are re-endangering themselves to potentially catching COVID for a second time, particularly during these upsurges. So furthermore, in cases where there are lockdowns imposed, employers are faced with the difficult decision to pay out of their own pockets to support their employees in the times where they can't have them working, or they have to face these severe economic implications, or simply let staff go, which is not what anyone wants. So I do think it's an extremely difficult balancing act. You also need to consider employment laws within individual countries, both middle, lower, and upper income countries, and have to consider in all cases before we do anything further. What we do about that and what special support, I'm not sure. Everyone is suffering. It's a global pandemic. So as much as the higher income countries do have some level of responsibility to support the lower level income countries, there may not be the financial support there available. So I'm not sure. I don't know if my colleagues could assist.
Yeah. Anne, any thoughts from yourself?
I was actually answering a question in the chat box. So I missed some of what you were saying. I did get about the fact lower, middle and upper income countries are all affected. And I'm really horrified to hear about 30% unemployment in South Africa. Your economy was not doing well before COVID. I just dread to think what the long-term implications are in South Africa. I'm a frequent visitor. I do some pro bono voluntary work there. And the thought of what it's done is quite scary. So it is a global issue, and it's something that we all have a responsibility to think about how we can support our workers to the best of our abilities.
Okay, fair enough. Karen, I can see you poised.
I wanted to say I'm no politician and I don't do the political game very well. But one thing that I think is really significant is that governments are going to have to find ways to support businesses, to support individuals. I mean, it's not just the ability to return to work, but the rehabilitation that these individuals are going to need is going to be extremely challenging, and those services are going to need to be made available. So I think this is something we governments globally need to just come to the party and support employers through this. There are many ways, taxations, etc., but it's not just for the employer to resolve these issues. It's a much bigger problem than that. I mean, we basically have a public health crisis, and we need to manage it as we would a public health crisis.
Yeah, it's interesting you say that, actually, because my next question is an extension of that. So maybe if we stay with yourself, I mean, keeping an eye on the Q&A, there've been a number of questions which are sort of related to this particular one. But given there are workers who, after 16 months, are still living with the effects of long COVID, I mean, is it realistic, do you think, to expect the employer to take on the burden of providing for those individuals? And if not, then how might that burden be shared, do you think?
And I think it's a very sensitive one to try and answer as well, because the reality is that for a number of those employers, and they are SMEs. We know that SMEs are the bulk employers globally, and they don't have the financial resources to keep people on their records indefinitely. And so the reality is that there is going to come a time when an employer is going to have to say, I can't go any further. So again, I think this is where governments need to come in, and there needs to be greater social support to assist those individuals, because the reality is in an economy where there is no social support, if you don't have a job, that individual is actually going to become a social burden at many levels. And to avoid that, I mean, I read research the other day that says that the average age of somebody with long COVID is 40 years old. These are people at the peak of their employment. We can't afford globally to just write them off and say, well, there's nothing that we can do to help you. So I think this is where there's going to be a need for creativity, and where governments come in and help those companies to kind of get these workers to a point where they actually can function again. You know what? The reality is there are a lot of workers who didn't have long COVID long before the pandemic, who things would have happened to them and they would have developed disabilities and couldn't carry on with their jobs. Well, what about things like retraining schemes, that we could look at reskilling people so that they can do activities that are not quite so manually intensive, etc. So I think this is going to be a time when the creative juices of governments, employers, etc., are going to be put to the test.
Sure. Anne, anything to add?
Yeah, I think in many occupations, people will have transferable skills and jobs are going to change dramatically. They've changed over the last 20 years. They'll certainly change in the future. Is there any way that those transferable skills can be built on? What I think is horrifying, to build on what you were saying, Karen, is somebody in their 40s that develops long COVID. Well, it's frightening to think that the retirement age is going up and up and up. And therefore, somebody who is 40 today without long COVID would probably have been expecting to take their state pension at the age of 70. So that's 30 years. Now, that's 30 years of work that if they have transferable skills, maybe those skills could be enhanced. And I think there's definitely a place for coaching and career guidance. And I don't mean the old school career guidance, but somebody with an idea of where that person can move towards. And I think nursing, as an example, somebody who's been working as a nurse, got COVID, got long COVID, is not able to go back to their clinical work as a, I don't know, person on a medical ward, but they may have skills that are applicable either to other areas of nursing or to occupations outside of nursing, because nursing gives you such a wide panoply of knowledge and skills that is applicable elsewhere.
I think I'm just looking at the Q&A at the moment, and to reinforce part of a message you've all said, and Murray has mentioned it in particular a couple of times. Patricia Anderson says that she's at 17 months with long COVID. I think that's what that refers to. But she also knows of people at 18 months and 21 months as well. So there are people with it who are getting better, and there obviously are those that definitely aren't. And I think that shows just the variation of how individually susceptibility, will change. And this is a very, very difficult thing to manage, because, as Murray has said, on a number of occasions, there's so many unknowns at the moment, and we're still finding our way through. So here's a big question, and let's start with Murray this time. Do you think this is potentially the biggest occupational health challenge of our era, long COVID? What do you say to that?
So I think in general, this pandemic is probably going to be a defining point in human history for the next 100 or so years to come. It's one of the biggest pandemic we've had in the world since 1920s. We've got massive globalization now, with people moving constantly between every single continent, including even Antarctica. And COVID is spreading. And the more that it spreads and the more that it infects people, the more likely we are to have more infections and more mutations and different variants than that. And unfortunately, the only way to prevent someone from getting long COVID is preventing them from getting COVID. So the biggest thing that we need to do now is we need to limit the spread as much as humanly possible, whether it's vaccinations or it's non-pharmaceutical interventions such as social distancing or wearing masks. That's what we need to do. And until we can successfully vaccinate the entire world's population, we're likely to see a continuation of the pandemic as we see it today, with the rolling waves that we see as new strains become more prevalent. So yes, I do think that this is going to be a huge thing, and it won't necessarily only be in occupational health. It'll be in every aspect. We're already seeing clinics popping up all over the world. And fortunately in South Africa, we only have one that we know of that is dealing specifically with long COVID. And it's unlike any virus we've ever seen before, where patients become ill, they have symptoms, they either survive or they don't, unfortunately. And they, for some or another reason, they don't go back to normal. And as a result of that, it's something that we've never seen, as I said, and we'll have to investigate it much further before we can do anything about it. It is very worrying.
Absolutely. Anne?
Yeah, I think, as you were saying, we're not safe until everybody's safe. And so until we've got effective vaccinations across the whole of the world, there's going to be these risks. You just have to look at New Zealand, who closed down all their borders, and I nearly got caught there in March last year. They've still been getting occasional COVID patients. So, okay, they've not had many, but they have had some. Thinking about long COVID clinics, we've got long COVID clinics in the UK, whereas South Africa to only have one for the whole of that country is worrying. But it's going to be a big financial investment for countries, for their health services, to establish long COVID clinics. And it may not be possible in the lower income countries. My feeling is that all healthcare professionals should be considering that long COVID is the major public health issue in the world, but looking at the UK in particular, all healthcare professionals should be aware of the implications of long COVID and be thinking about how those can be addressed.
Thank you. And Karen.
I don't want to kind of just repeat what Murray and Anne have said. I support both of them full-heartedly. You know, I'm going to try and take this from another perspective. I think this is also an opportunity in the sense that, you know, often the medical model is that you focus on a system and you go and see a neurologist or a cardiologist or a pulmonologist. I think another thing that long COVID has taught us is about this holistic picture of people again, that we shouldn't just be trying to compartmentalize one aspect of their health. So I think that for me is an important learning from this, that we look at people holistically again. I also think, and coming from an occupational health background, we are the Cinderella discipline. We always have been the Cinderella discipline. And I'm going to admit that I'm one of those people who had to go and study safety so that my employer would listen to me and take me seriously. And I think this is a great opportunity for IOSH, and not just occupational health, that we understand and we start working together more collaboratively, that we understand that we're not in competition. We actually need each other, because our job is ultimately to create that safe and healthy working environment. And I think this is a scenario that has shown us so effectively just how important it is going to be to actually collaborate more effectively into the future, not just at an occupational level, but also as a medical approach to looking at people as a holistic entity and not just a diabetic or a hypertensive, for example. Yep.
Yeah. From a personal point of view, I'm on exactly the same page as yourself, Karen. So personally, that's music to my ear. So one final question. I'm just keeping an eye on time. You know, time flies when you're having fun. One final question, and this will perhaps catch some of you on the back foot, and I don't mean to do that, but it's a question that's coming from Linda Jones, actually. Is there a fear that long COVID will be treated in the same way as fibromyalgia and other chronic pain conditions, in that it's a long-term condition, people just have to get on with the work, and because everybody's suffering, then all of these options are no longer feasible? Just a 60-second review on that, if that's possible. Perhaps Murray, can I come to you, or is that a little bit unfair?
So this is something that we have discussed. We've actually been in discussion with the chronic fatigue syndrome and myalgia encephalopathy Centre in South Africa. And there is quite a lot of questions, even within WHO discussions, with regards to, is this similar to that, or is this an entity on its own? It's a very difficult question to answer, and I simply do not answer. I think the key defining factor is that long COVID, we have a pathogen that we are aware of, that this is the most likely reason for it. With MME and CFS and all of that, it becomes a little bit harder, because obviously there's so many different viruses that we think may cause it. And even those conditions, they're very poorly understood, despite them being around for years and years. So hopefully with long COVID and the research that's been put into it, there will be some answers that can be translated into these different disciplines. And hopefully it'll be able to be expanded to include them so that we don't have patients who are left behind. No one wants patients to be left behind. None of the doctors or scientists want patients left behind. Sometimes there is unfortunately very, very limited answers that we can give. And hopefully that with the advent and the amount of research going into long COVID, we can actually give answers to these things that were previously left unsaid.
Okay, that's great. Thanks, Murray. So if it's okay with you, Karen, I'll leave Anne to perhaps give her point of view, and then we're almost out of time. So Anne, any further thoughts?
No, I think what this webinar has underlined is the importance of looking at people as individuals. Also, as Karen was saying, that if you've got a respiratory problem, often you're referred to a respiratory specialist, or if you've got a musculoskeletal problem, you get referred to a musculoskeletal specialist. But long COVID covers all of those parameters. So it's like a Venn diagram, and it's thinking about how we can have person-centered approaches to supporting the person from a health perspective, but also within the scenario of being in the workplace. So working effectively to help that person return to work, supporting managers. One of the areas that I think managers need quite a bit of help on is thinking about mental health issues and how to deal with those. And I think everybody on this call is likely to have encountered the HSC website. I know not everybody's from the UK, but there's some very good resources there, particularly in relation to stress. Now, if somebody has got long COVID, they're returning to work, they don't have any control over their job demands are excessive, that's going to make their effective return to work recovery strategy less effective.
That's great. Thanks, Anne. Well, I mean, that seems to be a great way to draw things to a close, because believe it or not, that's an hour. A very thought-provoking and important discussion, though, across that hour, I think. And I've certainly learned things along the way, and I think we've had some really good prompts for further discussion as well. But I think, you know, there's time for me to thank our three panelists today one final time. So thank you, Dr. Karen Michelle. It's been great to get your insights. Professor Anne Harris and Dr. Murray Dryden, thank you for taking the time, to all of you for coming along. And I also want to thank each of you for taking the time and tuning in and listening as well, and very much being an active part of this webinar. And I apologise that we haven't been able to get through all of the Q&A and the questions, but it's clearly a very, very important and topical subject area for everybody. So please be sure to check out IOSH's online coronavirus resources pages, where some of those questions may well be answered, and there's a lot more essential content for you. So continuing to showcase the issues that will face IOSH as a profession as we move forward with coronavirus, our final webinar in this series will look at what next after COVID-19, and that will take place on Thursday, the 30th of September. Details will be available on the IOSH website, again under the COVID-19 section. So once again, thanks to everybody from wherever you dialed in from. We really appreciate your time and attention, and please stay safe.